So welcome everybody today. This is actually our sixth session now of the Global Epilepsy Surgery Techniques Rounds. We've got a great session ahead today. We have two fantastic speakers to talk to us about tuberous sclerosis complex. Just a couple of reminders. Please mute your audio if you're not speaking. Please, if you have questions for the speakers or in general related to the topic, use the chat function. We're going to have our two presentations, and then we'll have plenty of time to get through questions at the end. So it's a minute after 10 now. So to give everyone plenty of time, let's go ahead and get going now. And so as I mentioned a minute ago, we have two fantastic speakers today. Our first speaker will be Professor Bertil Reidenhag from Gothenburg, Sweden, who will be talking to us about surgical treatment in tuberous sclerosis. And that will be followed by Professor Howard Weiner, who is the neurosurgical chair at Texas Children's, who will be talking to us about the evolution of TSC surgery for epilepsy. So without further ado, Bertil, welcome, and we look forward to your talk.
Thank you. Is it working?
Yep, perfect.
Dear all, I'm very honored to have been invited to give a talk about this very difficult patient group. I have no disclosures. Tuberous sclerosis exists in multiple degrees of severity. The etiology is a mutation in one of the genes controlling growth and cell division, TSC1 and TSC2. As you know, this is part of the M2 complex. Mutations in TSC2 are more common than in TSC1. The disease is an autosomal inherited disease, and the tuberous manifestations may occur in multiple organs, such as the brain, kidneys, the heart, eyes, lungs, and the skin. There is a very good overview recently in the book Pediatric Epilepsy Surgery, edited by Alexis Arsemanaglu et al. Tuberous sclerosis can be devastating both due to the inherent resulting deficit in the brain function and due to the very frequently occurring severe epilepsy. Surgical treatment may be very difficult, mostly due to the multiple and often bilateral epilepsy onset zones, often present or that they are located in a close relation to the eloquent cortex. However, if a specific tuber may be identified as at least the main epileptic focus, surgery may be a good option, both with the aim of getting seizure freedom or to gain a substantial reduction of the seizure frequency. So let's look upon the possibilities for success of epilepsy surgery in TS. First, seizure freedom. Well, sustained seizure freedom for several years is not likely real, but you can get results with a subselect of patients. So the goal is mostly palliation, less traumatization, and this might be the achievable goal. And it's very important to have even short periods of seizure freedom and palliation. I will come back to that. So this palliation may be a worthwhile reduction of seizure frequency and or severity, halted cognitive decline, halted behavioral decline, and hopefully quality of life improvement. So what about anti-epileptic drug discontinuation? Well, certainly not, or at least absolutely most probably not. In this patient group, it is, as is all of these patients, really important not to have any complications. I mean, it's a very difficult group. You have tubers very close to eloquent areas, and the relapse of seizures are very frequent. You could easily give the patient a double loser situation with sustained or relapsing seizures and a neurological deficit. So it's like they really need a very close evaluation. For the cognitive outcome, it is important to reduce the severity of the epilepsy, even if the long-term seizure outcome may be poor. The most fundamental part of surgery in TS is to localize the seizure onset zone with an advanced epilepsy surgery evaluation, which also may include invasive monitoring and 7 Tesla MRI, FTG and or AMT-PET, Epilespy and SysCom, MEG. availability of intraoperative MRI may be an advantage to evaluate the completeness of the dissection, but is of course not necessary. It has been extensively discussed whether it is the tumor itself or the closest cortical rim that is epileptogenic. There may also be dysplasias associated with the tumor, and actually that is probably more common than we think. Most agree on removing the tumor completely and any surrounding cortical rim if on a distance from eloquent cortex. The completeness is best checked for with a post-resectional intraoperative MRI scan. Even if TS is an often devastating disease, especially for those with many tumors, giving both a severe seizure situation and worsening the cognitive and behavioral decline, the general epilepsy surgery principles are still there, and I think that's important. If on the left side you see a single lesion in the middle part of the temporal lobe, and on the right side you see several lesions, they're not very typical, very easy to see with the bilateral tubers. These two patients are, of course, as in general in epilepsy surgery, completely two situations. So the fundament is the history, seizure semiology, neuropsychological evaluation. Then the imaging is very important, MRI, PET. The EEG evaluation is very important to get a congruent EEG with the other findings. And as we all know, it makes a very important difference having one unilateral lesion, even if TS is suspected. I mean, that might give several spots that are not visible really, but compared with having multiple bilateral lesions. In addition, you may find on MRI or in the pathology dysplastic cortex near the tubers. So resection of the identified tuber in the epileptogenic zone is one and perhaps the most promising situation. Then you can have resection of complex of tubers, which I think Howard will give an example of. They are most likely being close to each other. Multiple stage procedures are another alternative. You can reach a palliation via corpus callosotomy if, for example, drop attacks is a major feature of the semiology. And also focal resection and an adjunctive callosotomy has been described. The following example illustrates a single large tuber in the medial part of the left temporal lobe, the epileptogenicity identified by conventional methods. And I already showed this image, and it became a TS after pathology examination. So this is the surgical approach, just to show you the consistence of the tuber. So this is in the left sylvian fissure. And very soon here you will see a different, you will see the pathological appearance of the tuber. And it behaves strangely. It is a hard consistency, and you see calcifications in it. And this is, of course, a good situation. This is the post-operative MRI, and this patient became seizure-free, not unexpectedly. Then to identify one tuber or one complex constituting the epileptogenic zone is thus fundamental, and there is a possibility also to get valuable information from AMT-PET. AMT-PET was described by Shogani in the 90s to have the ability to highlight epileptically active dysplasias and tumors. If a distinct tuber is visible on the AMT-PET and the EEG evaluation is congruent, as well as the evaluation in total, the semiology and MRI and everything, then you may probably go directly to surgery, if not close to the eloquent areas. Howard Weiner will, among other things, present the multiple invasive approaches. I will discuss the usefulness of the AMT-PET for the evaluation. And AMT-PET is, however, not universally available and is quite expensive. But recently, the method was set up in Uppsala, Sweden, handled by Torsten Danfors, where we have sent our patients. The following slides illustrate a young boy with tuberous sclerosis who was evaluated with AMT-PET. He is, however, not operated yet, but it looks like this. This is the first slide. You see an increase of the AMT, and you can just see the disrupted structure, and it will become more and more obvious when you go to the surface. Here you have the anatomical appearance, and it is congruent with the increased uptake of the AMT. It's immediately in the precentral area, so when we further on will go on to surgery, we will probably have to use MAP or motor mapping. Here is an example of a boy 1.5 years of age at surgical evaluation. Onset of seizures at 3 months of age. The first semiology was clonic movements in his left side, which gives us, of course, a lateralization of a possible right side focus. He had also absences and chewing movements. First evaluation by a neuropediatrician at 4 months of age. History of seizures and early development retardation. Obviously late in his development already at that time. Here is some selected slices, and here you can see a tuber in the basal frontal right side, which we immediately thought could be responsible for this type of seizures, but he has also several other tubers. And as you can see here, they are, however, mostly on the right side. So we got him sent for an AMT-PET, and of course he has uptake in other regions, but this basal frontal part was the absolute most significant uptake. So very significantly increased uptake in the right basal frontal tuber. The decision was then made to suggest to the parents a resection of that tuber, including information of the surgical risks in a 1.5-year-old child. Furthermore, it was important to inform the parents that they should have moderate expectations and more regard surgery as a palliative procedure. It was also important to inform that the procedure was only directed towards the seizures and that the cognitive further development would still not be normal. As we all know, quite often parents have unrealistic expectations on epilepsy surgery. Most of us know that, and we have experienced it. They may have the view that also other problems than the seizures may be more normalized, but that is, of course, not always the case. So we made a surgical plan, and here is some of the overview. And here is a video clip. The surgery is performed of one of my younger, very skilled neurosurgeons, Donja Nilsson. It's a little short. It's a short video clip just. Very soon we will see the olfactory tract and the optic nerve, and also the carotid artery. And here he is inside the tuber, and you can immediately identify the consistency of the tuber with a stiff appearance and higher consistency than normal brain. So this is quite typical tuber. So we have the possibility to do post-resectional intraoperative MRI. So here are the preoperative scans, and here are the intraoperative post-resection MRI. And as you can see, the resection seems to be radical. And so far we have 24 months of follow-up, and he has been seizure-free until very recently. One problem is that some of the other tubers or an associated non-recognized dysplasia might get active in the future. Pathanatomical examination verified the diagnosis. However, as you know, the pathological features are identical to a dysplasia FCD2 when examining the tubers only. The diagnosis of tuberous sclerosis is made, of course, on the whole clinical appearance, and often you use also genetic testing. So he has now got quick, sudden generalizations with zero drop attacks, and they are really very bad for him. He has generalized EEG features, quite common. This type of deterioration is quite common in the children, but he has anyway got almost 2 years of cognitive development. So here is the EEG very recently, and he gets several drop attacks falling forwards, and here is a still picture from one of the situations. He does this several times over and over again. He sits up and then he falls forwards. So we are actually now going for a callosotomy after this. Then we have a boy 5 years old, multiple tuberous, severe seizure situation, non-invasive evaluation support seizure start behind the left central region. MRI revealed a larger tuber there, which was also calcified. So we had the possibility also for this patient to do a AMT-PET, but here you see first the MRI scan, and you see that it is in a little bit tricky area. It is post-central, it's close to language areas. So we did a tractography. Also, it's quite close to the arcuate fasciculus. And we made a surgical plan after that. And here's the AMT-PET, and you can see that this is very, very obvious, even if you can see that other tubers also do take this increased signal. Here's just an overview of the surgery, and on the surface you don't see anything. So using the navigation, you can easily identify this part, and very soon you can realize that this is the stiff type of tuber, and this is the post-resection cavity, and this is the specimen, which is very typical for a tuber. And he got really a substantial relief in seizure frequency, and it's now 2 years ago, and he still has more than 90% reduction in seizure frequency. So far it's good with him. Then we have, as the last case, a boy born 2004. He has had multiple tubers, frequent and traumatizing drop attacks, not possible to localize a focal onset. He had also a subependymal giant astrocytoma. And we suggested a complete callosotomy, and this was performed June 2012. It did get a relief for him, even if there was a later relapse. Due to the SIGA, he got also everolimus, and sometimes you can get a seizure reduction using that everolimus too. And this is the MRI 2012. You see the SIGA here, and you see also multiple tubers in this T2 flare scan. Here is the MRI before the callosotomy in 2012, and the MRI 8 years after callosotomy, and you can see that there are no remnant parts of the corpus callosum. So 2017, the SIGA was removed and everolimus was saponated. Due to the increasing seizure frequency, he also got a VNS. To give some comments regarding this last case, it illustrates really difficulties in handling these patients. Over and over again, if you work with them, you can achieve better seizure situations, sometimes sustained, but however, quite often a relapse comes sooner or later. Still remembering that even short periods of seizure freedom or seizure frequency reduction, these periods are very important for the cognitive long-term development. Some overall comments. Children with TS, especially multiple tubers and multiple seizure onset zones, are difficult to handle. However, in the early age, it is for the cognitive development very important anyway to try to reach periods of seizure freedom. And the same basic principles, I would say, are very valid as in epilepsy surgery cases in general. You can end up in a focal resection, multiple resections, stage procedures, or callosotomies. In selected cases, you can, however, get a high proportion of seizure freedom. But I think it's also important to remember that the cases that are possible to treat surgery and may be selected for a surgical evaluation probably constitute a very selected proportion, a small proportion of all children with TS. Anyway, it is important to do an individuation in the individual case to see if anyway not a palliation is possible, even for a short time. So thank you for your attention. This is the Sahlgrenska Hospital. These are my colleagues in neurosurgery and clinical neurophysiology, and these are a neuropediatrician. And I will give Torsten Danfors from the Uppsala PET Center a special thank. And I also will give my favorite colleague a very special thank. He has been very supportive until he falls asleep. Thank you.
Thank you, Bertil. That was a wonderful talk. And please, for any of the participants, add questions that you may have for either Bertil or for Professor Weiner to the chat function so we can address them at the end. So we're going to move on with Professor Howard Weiner from Texas Children's Hospital, who's going to speak on the evolution of TSC surgery.
Can you folks hear me and see me?
Yes.
Okay, great. Thank you so much, everybody, for the kind invitation. I'm excited to talk about this topic, which has been a focus of our work over the last 20 years or so. And my goal is to keep it very practical, sort of to give you a sense of how I do it, what the lessons we've learned, and sort of the evolution of our work between my move from New York to Texas. Let's see if I can advance my slides. There we go. So, you know, I think that the history of tuberous sclerosis surgery really mirrors how we view epilepsy surgery in general over the years. And this was sort of the age-old theoretical debate between Penfield and Talarak. And I think the early work, as I'll show you, on tuberous sclerosis really viewed the subset of patients who had good localization and had sort of a dominant focus in the brain as tumor surgery. However, we know that a majority of patients with TS have poorly localized epilepsy and what we would call sort of network dominant TS. And those patients were treated either without surgery at all, or they were offered palliation with callosotomy. And a lot of our work was really to try to identify that occult focus within the network. And as we know from the cases we saw so beautifully on the last talk, there is a continuum on how apparent that focus is within the network. As I mentioned, my old boss and mentor, Pat Kelly, treated these cases as tumor operations and had good success in those patients who had well-localized single focus TSC epilepsy. And we do see some of these patients as example here. This was a young child who had this central calcified lesion, and with monitoring and extraoperative mapping and intraoperative mapping, we're able to remove this focus. And this is a very satisfying case for us. And the early literature on TSC really focused on these patients, those who had concordance, those who had good prognostic criteria. So there was imaging and EEG correlation. They had a unilateral focus. They had mild developmental delay. They had none of the features that would suggest this network dominant type of TSC. So this is another example of a child who did very well. This child is now in college. This is a typical approach. This was a child we treated here in Houston, a year and a half old, where we did have clear localization, but we wanted to sort of tailor this with some extraoperative mapping of motor function, and also to really hone in on exactly what to resect. And this is an example from our intraoperative monitoring. We use these pediatric grids, and this was a technique that we did a lot of in New York. The challenge, though, and this is a technical seminar, so what do we resect here? And this is often the dilemma. Here's the surface of the brain. You can see sort of an expanded, somewhat discolored surface to the brain. And what exactly are we resecting here? And as we heard in the last talk, do we resect the tuber alone? Do we resect a margin beyond it? What tools do we use? Do we use intraoperative ECOG or invasive EEG? And we evolved into using a lot of invasive subdural chronic recordings with depth electrode recordings. And as you can see here on the opposite side, the cut surface, you see that the pathology, even though it may seem focal on the MRI or intraoperatively, we know that this is a diffuse pathology most often. So as I said, in New York, we favored using, and this was work I did with my colleague Oren Davinsky, invasive electrodes, and we were able to use MRI scan to see and grade whether our electrodes were perituberal, unrelated to the tuber, or in the tuber themselves. And Tracy Ma, who's now a chief resident at Penn, looked at this and actually found that we did see seizure onsets both within the tubers and around the tubers in this subset of patients that we studied. And this is obviously a very hot topic of discussion. And I think it largely reflects the fact that this is a heterogeneous group and that there are different patients and different patient selection criteria for surgery. So in this group's hands, they found that the epilepsy always started around the tuber. And in the excellent work by Simon Harvey and his colleagues, they find in the patients that they choose for surgery that seizures only occurred within the tuber themselves, and even in many of them in the center of the tubers. So this is an example from their work showing that the seizures really only started within the tuber and not around the tuber themselves. And we were very interested in this topic, and we looked at this actually with Guy McCann. And this is one variation of that work, that the brain around the tuber is also quite abnormal, both in terms of the histology and molecular features and also on imaging. So we have TSC patients who have normal looking MRI scans, and they have the clinical diagnosis and the genetic diagnosis of TSC. And of course, when we look carefully with imaging studies, we can see that the brain is not normal. And obviously, the better tools we have to investigate that, such as 7 Tesla MRI scan, we can shine a brighter light on the brain and see the pathology much more clearly. The second major challenge, and this was alluded to in the last talk as well, is which tuber? What is the hot tuber? What do we go after? And in my experience, the majority of patients that we see, at least in our clinic, are like this. And I've come to call them network dominant TSC. They have bilateral tubers on MRI. They have very poorly localized epilepsy, and we really don't have a good surgical plan. Oftentimes, even with a really excellent phase 1 evaluation with MEG and PET and SPECT, we're still left with this question, which tuber to go after, if at all. And the strategy, at least when I was starting in the late 90s, which came out of this outstanding group, was, in situations where there was diffuse EEG abnormalities or unlocalizable epileptic abnormalities, palliation may be obtained by corpus callosotomy. When I started working with Orrin Devinsky in the late 90s, our strategy was a little bit different. We wanted to look for that occult focus within the network. And we did this. We didn't have stereo EEG in those days, even though Pat Kelly did train in Europe and was a big believer in it. We did not have that technology here. So we utilized bilateral craniotomies and burr holes for strip and depth surveys. And if we could identify a focus, we then focused on that area with a grid study or a grid strip and depth study. And oftentimes we would pair this with a post-resection invasive monitoring strategy, which in the old days we called a multi-stage approach. And we got a lot of criticism about this, but this really reflected the difficulty and challenge of these patients. This was one of the early cases that we did where we actually put in electrodes bilaterally. We identified a focus in the right posterior temporooccipital region, as you see here, and then the left temporal lobe itself, and did in a staged fashion at different times bilateral resections. And we thought it was important to present this case. And in fact, I'm still in touch with this family and this patient. He's now in his early 20s and he's employed and he's on single medication with well-controlled epilepsy. And when he came to us as a baby, he was not in a good situation. He had severe epilepsy and was very, very sick. So we started to think about this, and using the strategy that I mentioned, we would use this bilateral invasive technique. Once again, we did not have stereo EEG in these days. We would do bilateral mini craniotomies, often as how I learned from one of our former speakers here, Dennis Spencer. We'd put in strips, we'd put in depth electrodes. This is in this example below, this is one case where we missed the focus in the occipital region, and I had to go back and put in additional electrodes. We initially studied this child with bilateral strips and depths, could not localize things. We're very suspicious of this mesial occipital area, and we put a series of depth electrodes in. As you can see, we resected that tuber, and this child is actually seizure-free. I still see him here in Texas, although the surgery was in New York. And once again, this concept of post-resection monitoring was quite controversial. But we felt that it was useful in a way to understand what beyond the tuber or the resection that we carried out was epileptogenic. And this approach of the bilateral survey and the multi-stage surgery we carried out with, these are our first 25 patients that we reported in 2006. And as you can see, and it was alluded to, the early outcomes were quite good. But as we know, these patients are complex. And if you follow them long enough, you will find that they may have seizures from the primary treated site or from other sites. And this is something that we need to conceptualize, and I'll talk about this later. Now, to get into the notion of how we do tuber resection. So for me, a cortical tuber, and we're teaching the residents and fellows this, they are really expanded gyri. And they may involve several gyri, but the bottom line is they are an expanded gyri. They are firm. They're nice to resect because your intraoperative feedback is quite good. You can tell where a lesion is just by that feedback intraoperatively. There is generally a decreased vascularity. And the key is you must take them out to a clean peel margin. So typically what I like to do is an en bloc resection where you open the pia, and you can use a microdissector to dissect the lesion away from the pia, and therefore you're protecting the vessels that are passing by. As I learned early on, the CUSA was never used for tumor surgery at NYU, but we use it in every epilepsy case on a low setting to really remove that margin. If you can't en bloc resect it up to the pia, we use the CUSA very aggressively to get that margin clean. Oftentimes, it's very difficult to get the lesion up in the CUSA, so we will soften the tuber with a bipolar cautery, and it makes it a lot easier to resect. In our experience, and as I'll show you, we have not seen function within these tubers, although this is controversial. However, one can get collateral surgical injuries. So, functional mapping is absolutely critical in these cases. And what we have found is functional reorganization is common in these patients. And we tried to understand this concept in a small series of patients here, 15 patients that we looked at, where we were able to get good resections without long-term deficits in a series of patients. Although now with RNS and with other stimulation strategies, there are many more options for these patients, and this comes up in our hands. So as I'll show you in the video, this was one example of a patient where you can see the electrodes in the upper panel, the electrodes, depth electrodes going in. This is a case we did in the old way with a craniotomy. You can see that interhemispheric strip, and you can see in the middle panel, we're developing a plane around the lesion, and the lesion itself, as I'll show you on the next slide, comes out basically en bloc. Let's see if we can show this very short. You can see here how the lesion itself really is like a tumor, and you can lift it out, and you can have a nice result. And I'll start this video here. This is sort of showing our resection of a region of tubers. So this whole area wasn't one single gyrus, but it was a region of gyri that were abnormal. And this was sort of the style of work we did in New York, where we would resect the lesion, and then we would place electrodes in for post-resection monitoring. And this was an extremely common technique that we used in New York. This is not a technique we do a lot of at this point. I'll show you our strategy now in Houston, and we're still doing post-treatment monitoring in a lot of these patients. For my craniotomies, we would take a pericranial graft, as you can see here, from the outer layer of the skull, and that we found was critical for our electrode placement. You can see here I'm working with Dr. Teresa Hidalgo, who was our fellow, who's now attending at NYU. You can see we use image guidance, obviously, but you can see I've marked out the lesion to be resected on the skull already. This is our craniotomy. You'll see this is a very basic case, how we do it, and I'll show you lifting the bone off. You'll see the dural opening. See if we can go back. Let's see if I can get a little further along. along a bit. So you can see the surface of the brain here. You see that rather pale expanded gyrus. We're doing intraoperative ECOG in this case, as you can see here. And I wanted to show the resection of how we actually do it. This is the ECOG. And here we are. We're removing a cluster of tubers here involving multiple gyri, similar to what we saw in the last talk. The brain is extremely firm here. Here we're opening up the PIA, not to the margin, but we're just getting into it here. You cannot remove, I have difficulty removing multiple gyri en bloc, so I will take out this huge portion and then remove the rest with the CUSA subpially. Let's see if I can move it along. Having a little trouble here. Here you can see the cavity, and then we get in there with the CUSA. For some reason the video is not showing now. This is us putting our electrodes in, post-resection monitoring. I'll just move it along. Oh, well, the video is not working well. We'll advance it. This is sewing in our pericranial graft. Okay, move along to the next one. So, you know, this became, you know, of interest to many groups. And this is one cooperative study, which was quite fascinating because, you know, there was a tremendous concordance between a lot of the groups about the experience that basically half to 2/3 of patients had a very significant benefit. And they did find in this retrospective cooperative study that resection beyond the lesion itself seemed to make a difference. But what they did find very interestingly is that if you follow these patients long enough, you see the seizure-free rate is degraded. And obviously this raises the question that we heard in the last talk. What are we doing with these patients? The goal of no seizures, no side effects, I think is really not achievable in many of these patients. So, you know, it raises the question in TSC, this is particularly relevant in this group of any epilepsy surgery for which the expected outcome may not be seizure freedom. So in TSC, we target the most problematic seizure type for that individual child, even if you can't stop all the seizures. And we know, based on this study that was recently published, that we participated in a large cohort of patients, that even achieving seizure freedom for the most problematic seizure for that child, but not rendering the child by definition seizure free, has a benefit in terms of neurodevelopment. So we try to achieve the best result we can for that individual child. And so the changing concept in TSC is, rather than performing a corpus callosotomy in these challenging patients, is really to look for that focus within the network. And in New York, I showed you we use the craniotomy technique. But now that I moved to Texas and I partnered with Dan Curry, who we heard talk about hypothalamic hamartoma, this has been really an incredible partnership and effort together. And I always use the concept of working with Dan is like 1 + 1 = 3, because we've really partnered both a conceptual and technological work and put it together. And all of these patients get a very standardized phase 1 evaluation with all these studies. And instead of performing a craniotomy now, we're performing SEEG to look for the actual tuber that may be the most relevant. And of course, this is not the indication for SEEG. When I initially discussed this with my colleagues who introduced SEEG into this country, I think the reaction was somewhat surprised. This is not the way Talarak and colleagues envision SEEG. Of course, pairing this with laser ablation was technically very feasible. And so, as I'll show you, one of the first patients treated with laser ablation here in Houston was a TSC patient. Of course, we know that compared to the craniotomy technique, this is much better tolerated by the patients. And if we're looking at a population that may require many interventions over their childhood, this makes sense, pairing the risk benefit with sort of the expected outcome. This is Dr. Curry and I are working together, and you can see on the bottom middle panel the number of electrodes we planned. In this patient, 17, although the patient that we operated on this week, 28 electrodes. Each electrode is selected based on a pre-surgical consideration. Of course, Dan published one of his first patients was a TSC patient. So I'll finish up with this 23-month-old, which is fairly standard. She had had a left-sided resection, as you can see, and remained poorly localizable. We were concerned about that right central tuber. We planned all of the electrodes here based on all of the phase 1 data. We named them. We discussed this with our epileptologist. Here you can see sort of the cartoon. And sure enough, her clinical seizures, the ones that were causing her to fall and were clinically relevant, were all coming from that right central tuber. Now pay attention, look at the number of subclinical seizures that were coming from the contralateral hemisphere. I think this issue of subclinical seizures is huge, particularly in childhood, and is something that will be the next important topic that we focus on in TSC. But we chose to treat this main seizure focus. As you can see, the electrode here at the bottom of that tuber, right there, the seizure onsets, and we put in a second laser fiber. Dan lasered this child, and this is now going on 5 years, and that detrimental seizure type is completely gone. She has other minor seizure types, but she's made tremendous developmental improvements. And although she's not technically seizure-free, she's improved. So is this a surgical failure? We would argue not. And so we've really looked at this now here in Houston, and have sort of found two general categories of patients. The ones who I would call focus dominant. These tend to be the younger patients before their networks are quite involved. We look to resect or treat with laser. We can talk about that. In eloquent areas, we now have RNS as an option. And in the network dominant patients, we're treating a lot of these with SEEG before any kind of treatment, which can either be resection or laser ablation. This is sort of our treatment algorithm. So based on our discussion at Epilepsy Surgery Conference, I would say that the majority of our patients are non-localizable, and we're going to SEEG. And it's the very rare patient where we're unable to identify any treatable focus. Whereas the main dominant focus patients are relatively rare. They tend to be the younger patients, and they tend to require the larger resections. We looked at our 38 initial patients. We're up to close to 70 now in the nearly 5 years I've been here. And we compared the standard craniotomy resection group to the minimally invasive SEG laser group, looked at the standard outcomes and the percent that were 50% reduced in the targeted seizure type. Very interesting cohort. As you can see, the majority on at least 3 medications, global developmental delay, standard, very involved population of children. Very interestingly, the ages were different. So this is not a comparison. This is just a demonstration of how our decision-making has identified 2 separate groups. The resection group was a younger cohort with a higher seizure frequency than the SEEG laser ablation group. Many of these patients had had prior treatment elsewhere, and many of them had retreatment. So some of the ones that we treated with laser went on to further laser in the follow-up period. Some went on to open resection, and some of the resection patients went on to laser. The outcomes were very similar. The only major difference were the length of stay. The resection group, length of stay 5.5 days. The laser patients, 3 days. But you can see that the majority did have a meaningful outcome. The median Engel class at follow-up was similar. So approximately 54 to 57% were Engel class 1 or 2 at this short follow-up, which was under 2 years. So this is our experience here in Texas. Of course, we have to report our complications. We had a case of hemiparesis. We had one case with the laser of a very bad brain abscess that had to be drained, and one patient who passed away a year after surgery from presumably from SUDEP, and other complications. So we have found that this hybrid approach of utilizing both the standard older craniotomy surgical resection and a minimally invasive approach can be both useful. and that this iterative approach makes sense. So the paradigm is quite different now. It's not just one operation and you're done. These children may require multiple interventions over time. You target the most symptomatic focus. You look for a benefit. If there's a plateau or if there's subclinical seizures, this minimally invasive approach is appealing in that regard. So this has been an experience. We've seen the evolution over time. The evolution reflects our general evolution about our understanding of what our surgical target is. Is it a focus? Is it a network? Or as I would argue, it's a network, it's a focus within the network. These are our colleagues, of course. This is work done in direct partnership with my neurosurgical colleague and partner, Dan Curry, and of course, our epileptologists who are outstanding. And I couldn't resist showing this picture from 2005 here. Dr. McCann and I visiting Johannes Schramm in Germany, which was a really incredible experience. And I will stop there. Thank you.
Thank you, Howie. That was a fantastic talk and a wonderful presentation. Again, for anyone who has specific questions, if you could add them into the chat function so we can go through them. While we're collating the chat, I have a question for both of you, actually, for Howie as well as for Bertil.
Guy, just before you start, sorry to interrupt. May I include some colleagues that wish to contribute to the discussion?
Yes, please do, Arthur.
Okay, so go ahead. I will be with you.
Yeah. So my question is, you talked about how these are very complicated patients, particularly the multifocal patients. So what are the things when you're looking at a patient that tell you that this patient is not a surgical patient to be evaluated? So in other words, you said at the end, Bertil, that we have a proportion of these patients. So what do you look at when you say, okay, maybe this is a patient that we're less likely to be successful in our evaluation?
I would say that is the occurrence of very multiple or undefinable foci. And of course, we will be very, very depending on the neuropsychological evaluation and the long-term EEG monitoring evaluation, and discussing if this is in any way any success rate in going on, and also of course the semiology. But it's, as I also stated in one of my slides, if you're in doubt, I think you should anyway try to do an individual evaluation for that, of course. I mean, just for having TIAs, you should not be excluded from epilepsy surgery evaluation. But I think sometimes you have to sort of stop it before you operate and start operating, taking out tuber after tuber and end up in a catastrophe. So I think you should be very, very careful anyway.
Yeah, so absolutely. I think obviously safety and patient considerations are critical, but it's been very interesting for me to see the evolution of thinking in the short time I've been here, in the 5 years that I've been here, because many of these cases that we would look at that initially when I got here, the threshold, the thinking was, it's not a surgical patient. And now the group that has been, in the trenches dealing with these children and families is quite the opposite. It's always the default position is they deserve a surgical evaluation, and what is the factor that will tell us otherwise? So it's a very different mindset, and it just reflects the fact that I think it's a general way to think about these patients is that, one can be cynical or throw one's hands up, and certainly you wouldn't be wrong. But, I think many more patients deserve a surgical evaluation than we've delivered up until now. And the main reason is because the alternative is so bad. And, adding another medication, I think the mTOR inhibitors are huge. I think gene therapy is going to be huge. I think stimulation paradigms are going to be huge. So all of these things will add to the options that we have for these patients.
Yeah, I think Howard, Bertel has a question for you directly.
Yeah.
Yeah, first I will say I completely agree with you, but it's very difficult to select the patients. But then I have a question. I thought your discussion with ECG and laser ablation are very interesting and probably very promising. Of course, we do ECG, but I have never done ECG in a tuberous patient. What happens when you place, two questions. First, what happens when you approach a tuber with your ECG electrode? Second question, how is it difficult to place the laser ablative electrode in the tuber?
It's a great question. We're able to get these electrodes into the tubers. Obviously, we're limited by just the number of electrodes we can put in. I mean, I think that, you can spend a lot of time thinking about the lesion itself, the region around the lesion. You have to have some hypothesis before you go into surgery. And that's why we use a lot of the phase 1 studies. We'll target a med cluster, we'll target anatomy, we'll target semiology, we'll target a SPECT. PET has been less helpful for us, but a SPECT abnormality. We don't have AMT-PET here. We have just standard PET. But as far as laser, Dan Curry, my colleague, I'll give him all the credit. He's able to target these lesions very, very easily. It's very interesting because, as I mentioned, with the bipolar, they're very sensitive to heat. So I wonder what the long-term effect on these will be with thermocoagulation. And once again, we're just targeting where we have the SEEG electrodes. So the SEEG electrode comes out, the laser fiber goes in, and that's the limitation of that technique. He can add, as I showed you in that one child, the 23-month-old, he can add a laser fiber to supplement, but in general, we're following, areas that we've recorded with SEEG, rather than, we're not just lasering what we see, on MRI.
Howie, can I ask you, so one is a philosophical question in relation to laser, and one is technical. So you talked about the importance in the surgical resection of resecting all of the tuber subpially. Yet the laser geometry does not allow that to happen. So you're really disconnecting the laser.
Yes.
And so do you think disconnection will be enough, or do you think that you're going to find fragments that result in recurrent seizures? So that's point one. Then in the technical question, your SEEG anchor bolt is usually much smaller than your laser anchor bolt, and you don't know which SEEG electrodes you're going to end up lasering. So are you changing out the anchor bolt, or do you put bigger anchor bolts in everybody?
To answer the second one, we use the larger anchor bolts to start with everybody. So we don't have that problem. We don't have to change the anchor bolts. Secondly, I don't know if Dan's on the call. I hope he is, but so we don't change the anchor bolts. That's number one. Number two is, you're absolutely right. You're trading the less invasiveness and the appeal of the laser for the, I guess, the anatomico-surgical precision of surgery. And that discussion actually comes up with the families, because a lot of these cases, there's a dealer's choice. You can actually choose one or the other. And a lot of times, for good reason, families will choose the less invasive approach first, and we'll quote unquote see what happens. We had a child that we treated 2 weeks ago who was here, where we did exactly that. We found a focus in the right central region. Dan treated it with 3 lasers. And we decided, and the family was extremely nervous. We put scalp electrodes on afterwards. Child was going to go home, then had a seizure. It was a bit atypical. Put the electrodes back on, and child's been seizure-free since. Went home happy. But that was a case where we had as a fall. I see Dan on the phone. I'm so happy. As a fallback, we had resection as an option. But I think most parents would choose the laser first if they knew it could be effective. And the laser is definitely effective. I mean, we have some patients who have never had electrodes placed, one with an orbital subfrontal tuber. That was the source of his seizures. Dan treated it with a single laser without any SEEG. That child's seizure free at this point. So it definitely works. The question is to you, will we get that margin, sort of that epileptic margin that, we're that's been the holy grail, I think, in this field. Dr. Curry.
Dan, are you on? Do you want to comment on that?
Yeah, first, I'd like to thank you guys. This is great, a great talk, and the two presentations were amazing. Guy, you hit it on the head. That's the limitations of the technique, is we really can't thoroughly ablate a tuber out to where we want to go. So we're hopefully grabbing the epileptogenic zone, but we really can't do any intertuberal analysis to the resolution that the laser would need. We can confidently get about 14 to 16 millimeters in diameter. Beyond that, it very much depends on the child and the age and the child's temperature and all sorts of things we can't really figure out yet. But it's been successful for the most part, but I have a feeling that's where the failures are going to be.
Dan, there's a question from Aria Fala, but I think a lot of people have the same question. When you're ablating a tuber, are you targeting the tuber with your margins, or are you targeting perituberal tissue also? And if so, how much perituberal tissue, and how do you decide?
When we're designing the stereo EEG, we design our trajectory through the tuber to allow a estimated ablation diameter. I usually use like 14 or 16 to cover the tuber maximally. And if I have to go beyond that, and I think that's going to be the important tuber, I'll put an extra trajectory in, make it the anterior half or the posterior half, or things like that. That's what we're kind of limited to do. And I put every stereo EEG electrode on these tuberous sclerosis kids, to a great degree, is designed to be an ablation corridor. And those that aren't, say it's motor hand, anatomically normal looking motor hand or something like that, that's going to be eloquent, then I'll use the standard 0.8 stereo G anchor bolt. But for the most part, I'm using the wider anchor bolts on these kids, as Howard's slide showed. And we strategize the trajectory to be an ablation corridor first. I hope that answers the question.
Yeah, thank you very much. Arthur, did you have one of the guests who wanted to comment? You're muted right now.
I was just trying to make Dan to activate his video, because he has a nice voice, but we still need the picture. If Dan is still there, would you please activate the video? Okay, good, nice guy. Yeah, no, there is a repeated questioning in here.
Dan, you're muted.
And maybe the panel and the panelists and the guests may try to answer. What will be the technical difficulties on performing and the utility of performing SEG in very young patients? Any problems of sticking the electrodes in? Any problems with the stereotactic localization? Any problems at all, or is just life as usual?
I mean, it's a very thin skull, and like with the rest of surgical considerations, we have to take that into account in terms of the anchor bolts. But I think that we've gone under 1 year of age with SEG, and I think Dan's been really very technically skilled in getting that done, in the very young age group. But we don't consider young age as a contraindication.
Our fight with that is knowing that the younger age intervention is going to be better for them developmentally. So we push the technical limitations of the thin skull. Yeah, some of them do loosen, but you can get a few threads of fixation, and then we have to, the head dressing is incredibly important, probably the most important part of the operation, because it has to build up this sphere of padding with gauze that stays above the height of these skull bolts, which, as you know, are pretty tall. and then put the head wrap on from there. And with that sort of careful wrapping and control, we very frequently go back to the operating room with stable bolts. Every now and then they're loose, especially those that are put in at an angle. But the ones that are square are typically still there. Now, if it's loose and the trajectory is lost, then we just have to redo the stereotaxy there with the robot. It adds about an hour and a half when I have to do that, but it's worth the try typically.
Yeah, there you go. I was asking if you could back your camera out a little bit. We were getting a very, very big close-up.
Sorry.
Maybe could some of our European colleagues maybe comment on whether they have any experience with using radiofrequency thermocoagulation of SEEG electrodes to predict whether the tuber is the epileptogenic zone and where it fits in the network? Does anyone have RF experience in TSC? Or Arthur, do you?
May I talk?
Please, thank you.
I am coming from Marseille, France, and we are dealing with TSC children. I am working in pediatric neurosurgery, and we are performing SEEG in children with TSC. Every time it's not a unifocal patient. But I think it's very difficult to put the SEEG before 20, 21, 22 years old in the temporal region. So to explore the upper part of the brain is not difficult, but to explore very, very young people with the SEEG, I think it's very difficult.
I'm sorry, Didier, you said 21, 22 years, but you meant months.
No,
right?
months.
Yeah.
Months. I made a mistake.
Yeah.
Sorry. Yeah.
And Didier, do you have any experience with using radiofrequency once you've done the SEEG?
No, we have not. We make thermocoagulation. Thermocoagulation inside the tuber, but it's for a few times. Sometimes we have result, but it's not a good thing. Not the laser. Only thermocoagulation.
But could you describe your experience with thermocoagulation and any peculiarities to TSC that you've noticed relative to other pathologies?
In large TSC, we have no effect with the thermocoagulation on the SEEG electrode. That's not good. It's not something very, very efficient. No, I think the laser is better and better.
And is that because the size of the lesion is too small?
I think most of the time we are dealing with large tuber, so it's not possible to put 3, 4, 5 electrodes inside, and you can make a big thermocoagulation. So you put 1 or 2 in the tuber and around, and that's all to delineate the epileptogenic zone, but not for coagulation.
Great.
Not good.
There's another question that's come in, and also this is for all of the panelists. When you have somebody with multifocal tubers, and obviously there's a big range, how often are you finding that there's really a single main dominant tuber and perituberal region versus do you find that there are multiple tubers that you have to simultaneously treat, as you showed in that case, Howard, of the bilateral patient who's now 20?
Yeah, so I would say that's probably the exception, and that probably reflects an early or less mature understanding of, and also a limitation of our invasive monitoring at that time. So now I think we are more precise in terms of identifying a region. So in general, we're able to treat a region, a complex of tubers, a region, a focal area, and that's what's so exciting about this, because these patients will get the best of possible, non-invasive workup, and still we're left scratching our head, and we'll put that together and try to come up with a cohesive plan, and we will find something. In the majority of cases, we've had a couple over the 5 years that I've been here where we just take the electrodes out, but that is extremely rare. And I would say I saw a question about the the risk of hemorrhage. The hemorrhage rate is very low very low. I mean, we recently had one non-clinically relevant hemorrhage, but most of these, they all get imaged post implantation, and they're in the vast majority there's no complication. So I think, you know, we're putting more and more electrodes in rather than less.
And a related question to the case, Dan, you know, Dan was talking about an orbitofrontal case, and Bertel had several single dominant tuber cases. How about when you have somebody who actually has multiple tubers, but has an AMT-PET or something else, some other form of high MR, you know, diffusion-based imaging that makes you think that that may be the dominant one together with the EEG? How often in people with multifocal tubers are you going straight to resection or ablation versus doing an invasive monitoring first?
We very seldom do invasive in these tubers, but if you have the semiology, EEG, and now so far in very few cases a positive AMT, I think that is a rewarding case type. But then I completely agree that it's probably quite uncommon that you have multiple tubers and you have one single tuber that you could sort of blame all the epilepsy for. But I think these are important to find because they are anyway a good surgical candidate.
And we definitely, yeah, I'm sorry.
Yes, sorry. No, sorry, please.
I mean, you know, there is that borderline between, I think the ones that you're talking about that go straight to resection are the ones that would always go straight to resection. They have concordance, they have physical findings that support your hypothesis. But there is that group where even though you have that single dominance, there are other factors. So the other tests suggest a med cluster on the other side or an AMT-PET on the other side or something. And those are the cases where we have the most in-depth discussions. We know, you know, we know that one area has to go, but do we want to study the whole brain first, or do we want to get rid of that? You know, we know it's necessary to get rid of that main focus, but will it be sufficient? So do we do the SEG up front, or we do the resection up front, and then if they fail, we do the SEG? So it's a great question, and that's a challenging group, you know, that particular group.
Usually I would probably prefer to do the first obvious resection because then you have eliminated that part anyway. But that is a tricky question. It is.
I would agree with that. Yeah.
Yeah.
Can I ask a question?
Can we? I just want to see Jorge on that last one. Can Didier comment from Marseille what their experience is, and then go ahead. Didier, do you often, if you think there might be one dominant tuber?
Yeah, most of the time. Most of the time, using stereo ECG, you find that there is one most important tuber, and you can go on to resect most of the time. But sometimes you have to make stage resection. That's unfortunately with TSC patients that's possible.
Jorge, I apologize for interrupting you.
No, it's okay. So I do have a question. We do have some experience with tuberous sclerosis and SEG in the beginning of the SEG series in our place. And our experiences, there are cases and cases that we discussed. There were cases that are very focused and the SEG really localizes and helps in the guidance. There are other cases that the synchronization of the tubers and the tissue around the tubers are so fast that in fact you cannot localize at all with stereo EEG. So the impression that we had is that if we have cases where the semiological features and the non-invasive features does not really point to a focality, the SEG will most likely will not improve the care of those cases because when we put the SEG, the synchronization between the tumors is so fast, even bihemispheric, that we cannot really pinpoint if there is a dominant tuber in what is the plan of the surgical strategy. So my question is there cases that you completely contraindicate any SEG exploration, or because there are no signs of focality on patient semiology that to perform an SEG will not provide any additional information. I think this is a question for both of the speakers. Perhaps Howard.
Yeah, I mean, yes, the answer is yes. I think you're absolutely right. And I think it depends on sort of the feeling of the group on that particular day, and, you know, sort of our experience with other similar cases. I think that it's very challenging. We would hate to, I would say the cases where we say no surgery are the ones who are basically doing okay. In the risk-benefit analysis, they're not doing terribly, but we definitely get these cases where the child is not doing well, and we don't have a good sense, a good hypothesis. And we would, I think now we would tend to still consider those patients because of the alternative. And but you're absolutely right. I think it's a very challenging area. It gets down to the philosophical question of, you know, because of most of these are lesional, do all these children deserve some type of study? I mean, it's very controversial. I wouldn't say that they do, but you know, that's sort of what's driven this field, I think, over the last 20 years.
So Howie, in a case like that, sometimes you'll have a scan where you'll see 30 tubers.
Yeah.
You know, there's a limit to how many electrodes you can put and where you put them. And so, I mean, you must be drawing limits somehow if your EEG is non-localizing.
Yes. Yes, absolutely. And once again, we don't operate on everybody. And I think that, you know, fortunately, in most of the patients that make it to the epilepsy service, there is something, you know, to push you forward. But I do agree with Jorge. I mean, there's definitely there are definitely cases where, you know, doing something doesn't make sense.
I could just.
May I ask a question, please?
Sure.
Hello to everybody. First of all, I'd like to make a comment on the enthusiasm of our North American colleagues about stereo G, and as a European neurosurgery, I am particularly proud of this. Nevertheless, I must say that here in Niguarda Hospital, our experience is that we address this kind of children mainly based on non-invasive evaluation. We have only 2 cases of stereo G guided resections, and I must say that our results are not different, are in line with what you have shown, about 60% of patients seizure-free. We rely on mainly on the concordance between the outstanding tuber or the predominant tuber, which is the largest one and usually more calcified one. And when this is concordant with the ictal AG, not with the interictal, which is more likely to be disused or multifocal, we have we decide for resecting of the tuber. I have a question for the 2 speakers. First of all, if they have seen a difference in the seizure outcome, if the patients are positive for the genetic mutation TSC1 or TSC2, and also if they think that removal of perituberal cortex has an impact on seizure outcome compared to tuberectomy alone. Thank you.
I could start to comment because Gothenburg is a small place, so I can just actually say I don't have a large enough series to comment on that, but perhaps Howard, you have.
I would say that the majority of children we see have a TSC2 mutation, and obviously, you know, have the more severe phenotype, as we've learned from the literature. I think the questions are related, actually. I mean, I think that in some patients, the perituberal treatment is important, and we would love to know that ahead of time. And that's why we do not have a technique at this point aside from invasive monitoring. I remember early on, I talked to the now dean and CEO of NYU, Bob Grossman, who is a radiologist, neuroradiologist, Robert Grossman, and he recommended a MRI diffusion kurtosis technique to look at, on a very micro level, the brain. Because we know from autopsy studies, work by Peter Crino, et cetera, we know that the brain, very analogous to Pat Kelly's work on GBM, the brain can be loaded with these abnormal TSC cells that you can't detect on MRI. So I think it's very heterogeneous. We need a classification system. I think that there are definitely cases where if you resect only the tuber or even a portion of the tuber, you will have a good result. And I think that's fascinating, but there are definitely others where that's not the case. So I think the genetics and the notion of what to resect are related. I don't have an answer though.
Can I change the subject a little bit? You all mentioned, maybe all the panelists, you all mentioned the eventual role for neuromodulation in these kids. What would be the role for neuromodulation in treating tuberous sclerosis?
I'm going to defer to Dan Curry, who is leading the way in this.
Well, right now it's very limited. I mean, we just had RNS as a tool that we can apply to these kids, usually older children for sure, but we looked at it for youngers as well. And the jury's still out whether it's going to be able to control it. Basically, what we use it as, we really in two ways. We're looking at the classic use of RNS, which would be an electrode along what we believe to be a eloquent tuber, which Howard wrote a very good paper years ago about how these tubers can have function, and it's very important to consider that. And we had a recent case in which one was a visual cortex tuber that would have been a vision loss had we resected or ablated. So in those solutions, I think typical RNS application indications, they make sense. The other more interesting work is using it as a thalamic modulator, centromedian or pulvinar or really anterior nuclear group if it's temporal. There's some information applying RNS in this manner, very, very similar to the Mexico City thalamic modulation treatments of tumors, but it's being handled in a little bit more rigorous manner. It's promising, but certainly the sort of thing we're going to have to study for a number of years. But its application for these, for like a Lennox-Gastaut sort of diffuse epilepsy problem has shown some promise with the Spectrum Health Group in Michigan and soon to be published. So I think the jury's still out, but stay tuned on that. I think it's going to be an interesting solution.
Can I ask one more question to you guys who are doing tons of laser now? Obviously, laser is so appealing to parents, families, because of how minimally invasive it is. But what are your criteria where you look at a tuber and say, this tuber needs a resection, rather than say, let's see if laser works first? Because obviously much of the world is just going to be incorporating laser. So how do you decision make after the stereo EEG? This anatomy does not conform itself to a high degree of laser success. We should go ahead and do a tuberal and perituberal resection.
I mean, I'll start and I'll defer to others, but I would say that size is extremely important here. So if we've defined a real complex involving multiple gyri, that's important. If stereo has identified a lobe, so the classic example would be like a standard temporal lobectomy. We've seen that a lot in the younger age group who come with really localized but questionable other sites. that's the group that, where, based on your other question, do we do SEG at all? Or do we just start with a temporal lobectomy in that group, in that young group, and then see? So I think it's largely based on size of the region you've identified. If it's something that Dan can get with 1, 2, or 3 laser fibers, then we'll, as in the case I mentioned that we did a couple of weeks ago, then we'll try the laser first. Dan, I don't know if you have other thoughts on that.
I agree. I think it tends to be the young kids, tends to be the wider diffuse sort of tuber complexes that's going to take a lot of work to get to, where resection's better. Maybe it's a lobar case, as Howard mentioned. But the other aspect we need to add to that is the surgical difficulty. A lot of insular tubers, they may be focal, but and yes, you can resect them, but the morbidity rate is high. So laser is better for there. The orbital frontal region is frequently an area we prefer to laser rather than do a large operation to reach. So there's anatomic considerations as well, but for the most part, they tend to be younger, larger complexes, especially with the immature brain not being able to allow us to really demarcate the exact border of the tuber complex. Strategizing a laser approach is very difficult. So, and we also put it in the big context of the child. We expect all these children to have one open, big operation, in their lifetime, and maybe pick off the residuals with laser. That's kind of a theoretical bias, but that's, we try to, we do think of that. The surgical history of the lifetime of the child is going to be something we should think about.
Yeah, I want to ask a totally philosophical question, since we have many of the world's experts on TSC on this call. You have these children who have this oftentimes dramatic lack of neurocognitive development. Sometimes it correlates directly with seizures and sometimes it doesn't. Do you foresee in the future that we're going to be treating tubers for neurocognition independent of epilepsy?
I'll let others speak.
Bertel, what do you think?
Well, it's a very interesting question. I mean, that the prerequisite for that is that if you have a severe epilepsy and a cognitive decline, and you're going to treat a tuber or several tubers for a cognition, then you make the statement that you can do that, keeping the epilepsy and anyway gain it. So it's it's an interesting question, but I think you have to turn it several times around before you consider that, really. But why not be open for it? I mean, but if you cannot decrease the epilepsy frequency, then I think there will be no use with it, really. Of course, if you have lots of subclinical seizures, that might be a possibility. Sorry,
that's what I was going to mention. I think the subclinical aspect is really, Guy, where you're going to find the avenue of approach there. I think we as a subspecialty need to really figure out what subclinical seizures are and how effective they're going to be on the cognition of the child. And I do think that we should be operating for cognitive improvement. It's kind of what we do anyway with this multiple, multifocal, multi-seizure spectrum. We're already making decisions on maximizing the developmental improvement of the child, and basing our surgical strategy on that. Question is, what are these subclinical seizures? I think that, personally, I can't imagine they're good for anyone's brain. And if and what is a subclinical seizure in a baby who can't tell you anything? These are all very important questions that I think may influence the cognitive outcome of the child. And if we strategize on that, it wouldn't surprise me in 5 years that we're doing that.
The TSC consortium that, Martina Bevan, Jurian Peters, Joanne Porter, and groups, I showed that publication from Pediatric Neurology, is very interested in now setting up a prospective trial, because that study was on the under 2 group, the early surgery group, demonstrating, in a pilot fashion way, some developmental benefits. And you have to really look at how you're studying these children. We know it from the parents. We know it from seeing these kids that they definitely will have a benefit. So looking at surgery, similar to the way we look at a new medication, mTOR inhibitor, ACTH, something early on, which can have a huge impact in the life of the child if we can demonstrate safety. So I totally agree with Dan. I think that the way to get there is to look at the subclinical seizure issue first, because there at least we have a biomarker.
Howard, you showed in your video that you perform intraoperative electrocorticography in your cases. Inclusively, you've shown you putting some strip electrodes under the craniotomy on non-exposed brain. Would you elaborate on what would be the usefulness of ECOG in this case?
Yeah, I think that case was really more of an investigation because that case, that was a rare exception. I would say in New York, I rarely did ECOG for the simple reason that we were putting electrodes in. So I agree. The implication of your question, I don't think there is a benefit there. I think we did it mainly because that case was done with resection straight up without any prior invasive monitoring. And at least we wanted to confirm some epileptogenic activity intraoperatively before we did the resection. And generally I don't do ECOG. We do ECOG with the SEG, but we're not doing it for treatment purposes. But I agree. Your question is absolutely right on. I mean, there's no benefit.
And I think there's one final question here, and then we'll wrap up because we're getting towards our time. Is where do you guys fit in mTOR inhibitors in your paradigm of when to explore relative to when to try various mTOR inhibitors in terms of the multifocal lesional TSC patients?
I think we are far away from sort of trying mTOR inhibitors. It's usually if you at the same time if you have a big SIGA, then we could try it. Otherwise, I think we have huge difficulties anyway in Sweden to sort of try out different mTOR inhibitors. But that is, of course, a good subject for a forthcoming, hopeful prospective study. That would be the best thing, I should say. But right now, I don't do it more than for SIGA.
Howie, last comments?
Yeah, we find that probably at this point, the majority of our patients are on an mTOR inhibitor just based on the practice patterns here in the States. And it's very interesting because it gets into the question, we stop it, several weeks before surgery because of risk, wound healing, infection, et cetera. And then restart it several weeks after surgery. And it's interesting because that can, we've definitely seen situations where perioperatively the seizures change because of that maneuver. And we've had some challenges based on that. But I would say the majority of our patients that come to surgery are already on it. I think it's one of the major exciting developments of this field over the last 20 years. So I think it's fantastic. And there'll probably be more to say about that.
So thank you to all of our, both of our speakers for fantastic talks, to all the panelists for a really, really interesting discussion. Our next session is going to be on January 17th. We're going to be talking about aspects of neuromodulation. Arthur Kukert is going to speak on deep brain stimulation, and Jason Gerard from Yale is going to speak on responsive neurostimulation. So we'll see everybody on January 17th at the same time. And once again, Bertil and Howie, thank you so much for your great talks.
Thank you.
Thank you.
I will be opening the GoToMeeting room now for you.
Yep.
Thank you.
Thank you, folks.